Thank you very much. Hi, everyone, and welcome to our second session of exploring specialties in medicine. My name is Efrain Ribeiro, and I'll be the moderator for today's session. Before we start, I would like to draw your attention to the LinkedIn page listed here for notifications about future events. If you weren't able to make any of the other sessions, these sessions are available on YouTube as well, including today's event, which is being recorded. And the Q&A session afterwards will not be recorded. So please feel free to ask any questions. We have a great panel lined up for you today with a very diverse group of physicians who will be telling you their story and hopefully giving you some exposure to different subspecialties in medicine. I know that for me, thinking about different subspecialties in medicine was a very daunting task during my undergrad training when I first started thinking about pursuing a career in medicine. And this was even harder since I was the first person in my family to go to medical school. Hopefully, with today's session, we can continue to help demystify some of the different aspects about medical training and hopefully expose you to many different ways in which we practice medicine today in 2023. I think our plan is to have each of the panelists speak, and then in the sake of time, we'll save questions for the end of the session. So please write down any questions that you might have in the chat. And then when all three panelists have finished, we can go over them. So first up today, we have Dr. Curtiland Deville, who is a radiation oncologist at Johns Hopkins.
All right, so I'll jump right in. Thank you guys again for the invite, the opportunity to speak, and to those who are with us here this evening, and to those who are listening, in the future online. I'll basically, I guess I'll start and just tell my kind of journey or path to radiation oncology, and then what ultimately attracted me to the specialty, and hopefully that will help share some of clarify what we do in radiation oncology, since we're a smaller specialty and not necessarily as well known as some of the others. As was mentioned, Curtiland Deville, radiation oncologist at Hopkins. I originally went to, I did my training undergrad at Brown in a combined undergraduate and medical school program, and then did my residency training at University of Penn in Rad-Onc. And it was actually during my time, in medical school, I decided to take a year off between third and fourth year, and did a clinical research fellowship. And there's sort of two reasons for that. One, I had done a combined program and gone straight through. And as I was rotating through the hospital, realized, okay, maybe I want to take a little bit of a break, do some research, but also wanted to really think about what I wanted to do. I wasn't convinced. I had an initial interest in orthopedic surgery and sports medicine, but once I was doing my surgical rotations, didn't quite love it as I thought I should. And as I saw some of my friends who were interested in surgery and orthopedics, kind of the passion that they had. And I realized ultimately, as I was sort of thinking about it, the patients that most interested in me in that way were the cancer patients. So oncology kind of in general, I realized, and maybe looking back, I can kind of understand the domains, the pieces, the anatomy, the pathology, thinking about disease progression, where it starts, where it can go to, that sort of mystery of figuring out the staging, has it spread yet? Is it localized? And then coming up with a treatment plan, how are we going to treat this, whether it's local therapies, systemic therapies, and things like that. And so ultimately, did my research year, worked with some oncologists who referred a lot of patients to radiation oncology, and realized, kind of honing in that specialty in particular seemed to suit me. I think, as radiation oncologists, we do think of our treatment more of as a local therapy. So it may kind of align well with the sort of a surgical mindset. We're going to define a treatment paradigm. We're going to, deliver that localized therapy, and then kind of follow the outcomes for that local therapy. So I did my, applied, got into residency at Penn, and trained there and stayed there as a junior faculty member before coming and joining Hopkins. And I think, radiation oncology, what was nice, one, I liked also the technology. So, if you're sort of you don't have to be a super high tech person, but just like, new gadgets and toys and things. It sort of suits that profile because we're always trying to think about how to refine and, deliver treatment. And it just amazed me that you could sort of treat a person, cure a patient's cancer without, touching them, basically, if you didn't necessarily want to. Not that you should want to, but at the same time, we do invasive, treatments as well. So those who are kind of surgically minded, we have internal forms of radiation, brachytherapy, we call it, where for gynecologic tumors and other sites where you do, implanted radiation or temporary implants, permanent implants, and different things. So radiation is the type of specialty that also suits, I always say any specialty that you're interested in, you could actually have that expertise within radiation oncology, because really we treat, we're trained and we treat across the body through our training, CNS, thoracic, lung, breast, GI, GU, you name it. We're generally a part of the treatment paradigm. And then so ultimately you could work as a generalist. It used to be the theory that, if you wanted to be a generalist, you're likely in kind of a community practice. Nowadays, there's so many sort of mergers and health systems coming, together, taking over practices, that there are actually, many community practice or community-based practices, which you can have a disease site focus of as well. So you don't necessarily have to be academic. But back in my day, if you wanted to specialize and have a disease site specialty, generally you would stay academic, and that's ultimately what I did when I finished my residency training. And I was really interested in prostate cancer. I realized over time I started to understand, healthcare disparities, cancer disparities, and particularly for Black men having a death rate twice as high as white men for prostate cancer, and sort of seeing that firsthand and wanting to sort of understand and really just be able to treat patients. Felt like a lot of the men I was seeing and treating in West Philly reminded me of my family members or, uncles and folks who, when I was having a conversation, I realized, they could talk to me like a friend, a family member, and really ask all the questions they wanted, and really having that kind of experience. And so that's my primary focus currently is prostate cancer. So my clinic and research for the most part. But again, really radiation, you can have whatever sort of expertise, those who like to be a generalist versus those who want to do breast cancer, want to do brain tumors. In fact, many folks often find a pathway to radiation where they kind of may have started in one specialty, neurosurgery or gynecology, and then kind of veered and went into radiation, but still maintain that same kind of disease site specialty. I think, I'm happy to talk a lot about if questions come up or things in the chat around, decision-making or, more in depth and detail or mentorship or how I sort of got these opportunities. I will say just in general, one thing that I've learned over time is I wasn't the networking type when people said, you got to network, you got to meet people and that sort of thing. It was not me, but I realized over time that the sort of networking that I did well was just when I had a genuine, sincere interest in a particular topic, whether it's like diversity, inclusion, and being on a certain committee, or like I said, with prostate cancer disparities and, kind of connecting with people, colleagues, friends, people just with mutual interests. And those really led to, more and more opportunities in sort of a professional way. And I realized, oh, this is the networking. This is how I'm, gaining these opportunities. And really at that point, it became easy to kind of seek out these opportunities. And maybe the last thing I'll say is, radiation as a specialty, we're not known as well, but we do play an important role in cancer care and cancer management. So I think there's tons of opportunity if we think about, cancer's number 2 killer in the US after cardiovascular disease. Radiation, anywhere from half to 2/3 of cancer patients will receive radiation. So oftentimes people, I feel like, are surprised to hear that we play, such a role in can have such a role in the treatment and management of cancer. And ultimately that means that we can influence things like policy, screening, detection, staging, play a role in guidelines development and things where you really can be a leader in the team in advocating for patients and communities, whatever your interest or your skew is, that there's tons of opportunity within radiation oncology. So with that, I'll stop there and let the next pass it back to the moderator. Thank you guys so much.
Thank you very much for that great introduction to radiation oncology, Dr. Deville. I'd like to hear about how the patients that you treat and sort of your personal connection influenced your choice to pursue radiation oncology. And as a pathologist, it's always interesting to hear about these other specialties that play such an important role in caring for patients with cancer. Like you said, there's so many different ways to get it, to get at the same problem depending on what you're interested in. Okay, so next up, we have Dr. Antonia Phillip, who is a psychiatrist with VCU Health.
Okay, good afternoon or good evening, everyone, and thank you all for having me here. It's wonderful to see that we have this mentorship program going on. I remember being in something similar when I was, deciding and looking upon what I would want to do in a career, and so to be on this side of things is neat. So just to tell you about myself, I'm Antonia, and I was originally born in Trinidad and Tobago. And so, as a child growing up, I did go into international schooling. I had some private and Catholic school. But then for undergrad, I attended Howard University, the real HU. I was the class graduating in 2009 with Dr. Maynard, who I affectionately remember studying and doing a lot of courses together. But it was Phi Beta Kappa and summa cum laude in the honors program there in DC. From then, I had been going through a lot of different activities, extracurricular activities. I always loved teaching and volunteering, and so I found myself signing up for a program that was similar to Teach for America, which is, I think, more popular, but this was a tutor program with the match core that's in Boston in Mass, and I attended there. Basically, was involved in meeting the educational needs of disadvantaged young children who were also experiencing an educational gap. And I was so encouraged and influenced by the work that we were doing and the transformations that we were doing that I decided to attend their teacher training program as well. And I taught at a public charter school after that. So I was teacher trained. I did 1.5 years in master's in education while I was in New York. And however, I started, applying to medical school, which was originally always my plan. And I had gotten in a dual degree program, the MD MBA program at St. George's University in Grenada. So I attended there, and after graduating, I did do residency training at Cooper University, their Atlantic Care track, graduated class of 2021. And then right after, I attended a fellowship, a Geriatric Psychiatry fellowship at the Icahn School of Medicine at Mount Sinai Hospital. And I just graduated last year, 2022, so I'm fresh out of training at my first early career psychiatry job. And so why did I sort of so everyone's talking about, what kind of, influenced us into such a career. And so why I chose something like adult and geriatric psychiatry. First of all, going into medicine was always a passion, always something that I wanted to do as a child. And I feel like it's a calling, even though I had deviated a lot and had a lot of different, or an orthodox pattern or path to becoming a doctor, I still veered back because it's something that I always wanted to do. I loved the sciences, but more so I also loved medical sciences. And despite how corny, cliche this sounds, loved helping people, loved being able to especially work with those who were less fortunate or disadvantaged, disenfranchised, and including those, especially in my experience, those who were emotionally and psychologically affected. And so as a doctor, though, I decided that this was, of course, besides the calling, this would be a major impact, because not only would I be able to psychoeducate them, which I love doing as well. But also I can use both the biopsychosocial aspects and psychological interventions, and then diagnose and recommend the best treatment plans that include medicine. I also had a lot of great mentors. It's something about people who influence you into your careers. And I do have to say that I had some great mentors during my residency program and exposure. I also joined associations like the American Association for Geriatric Psychiatry. I went to several other meetings. I enrolled in scholars programs. I did research, and all in all, that helped shape my decision and career into psychiatry and geriatric psychiatry in particular. And so a lot of people want to know, like, what is the role of a geriatric psychiatrist or adult psychiatrist in general? And we do a lot of similar things to other doctors in diagnosing, assessing, and treating or preventing human mental, emotional, and behavioral disorders. We do also assess patients. We assess their mental and physical status to determine the nature and extent of their mental, emotional, and behavioral disorders. We also assess patients and their medical, psychological histories. Of course, we want to get their psychiatric histories. We examine patients to determine their general physical condition, and we order and order labs, imagings, neuropsychological tests, and other diagnostic procedures, which we also read and examine, and it helps to facilitate the most appropriate treatment plan for the patient and with the patient. We do prescribe and administer medication. Some of us also go in, we all have psychotherapy training, but some of us even go even further to dedicate time towards psychotherapy. We always inject it and should be injecting it into every session and encounter that we have with our patients. Brief, supportive, especially, is most common. We also do other physical treatments and rehabilitation programs. We arrange admissions for patients that, especially because I'm also involved in outpatient care, psychiatric care. So we can arrange admissions to hospitals or inpatient treatment if necessary. We do consult with others and supervise and work with other medical practitioners. We determine whether patients require involuntary treatment or commitment. And this is a scenario in where when we evaluate someone and they seem to be, usually it's a danger to themselves, a danger to others, a danger to property, or so grossly psychotic or in a mental health episode that they're not able to adequately care for themselves, have like poor reality-based thinking and poor judgment and insight, putting themselves and others in danger usually. And so we do have that ability to commit someone or involuntarily get them treatment in cases where relevant medical health acts are necessary. We can also definitely, I don't do this, so that's why I said they, in assisting courts and other statutory bodies, in managing patients in legal and forensic settings. And we of course are involved in teaching. I think all doctors, you have to be have a passion for that, or you'll do it in some way or fashion. That's how we propagate our profession. So medical students and residents and others, as they progress, we also administer tests and other things like that. So I was trying to think, like, what kind of skills are required besides like having a passion and never giving up on your dream, never thinking that it's too late to start something like medical education, medical school education, having oral, expression or oral comprehension is really important, written comprehension and written expression, because we do a lot of talking with our patients for the most part. We do also do a lot of listening in. So having good inductive and deductive reasoning skills, If you're also a person that is very sensitive and empathic, that definitely translates very well for the patient to be able to become comfortable with you and to trust you and to build rapport and treatment engagement and alignment. And then having patience, because sometimes it's just not as easy as, sitting there and receiving all of their history and their trauma. But problem solving, especially for behavior modifications. And then I think having good stress management, because in psychiatry, we do hear a lot of really sad, traumatic histories for patients, and being able to also because the demand is high, we're also busy like any other field, right? But being able to have a good work-life balance, being able to know how to de-stress, having a strong mind and emotional resilience, I think are some of the skills that are really come in handy in psychiatry, and including geriatric psychiatry. And so I think you all know how to get to being a doctor. You need a bachelor's of science, you have to pass the MCAT, you apply to med school, but then you do a residency program, in particular in psychiatry, the specialty of psychiatry, and this is a 4-year program. So once you graduate, you have the choice to continue as an adult psychiatrist, where you practice general psychiatry for those 18, usually to 65 years. Or younger. Some, because of, I guess, the demand, do practice into or see geriatric patients, but might be more uncomfortable with it. There is a subspecialty and multiple categories, but in geriatric psychiatry in particular, that's a 1-year fellowship training program that you go into. And you take a board exam and receive board certification at the end of that. A lot of the programs with ACGME are standardized, but also have a lot of flexibility, which I love. The ability to do a whole variety of different things and inject them, or inject your interest into the year and into the program. I did a lot of nursing home. I had ECT exposure. I did movement disorders and neurology. So I did a lot more of that, and neuropsychiatric and neurobehavioral in my training program. But in others, you can ask for time for research. You can do more time for psychotherapy. You can also be really flexible if you like more heavy medicine, because geriatric psychiatry, we do need to know a little bit more about the general medical conditions. You can basically navigate or design a program that might have geriatric medicine injected more into your program and in your training. For research and time for research, you can, after your clinical years, so geriatric fellowships, geriatric psychiatry fellowships, 1 year is usually very clinically focused, but you do have the ability to do some research. If you want to go in more in depth into research in particular, you can add a year. And a lot of programs like Cornell, Mount Sinai do have an extra year or even 2 where you can do research added on to it. So in total, it's a lot of years that you are devoting to being the best psychiatrist that you can be for anyone. And it's about like 13 years or more. We didn't really mention this, but the salary, it varies. I was looking at the US News and World Report, and the most recent was in 2021. So for psychiatrists, they had mentioned that it is the number 7 in best paying jobs, number 12 in best healthcare jobs, and number 32 in 100 best jobs. And psychiatrists are making a median of $249,760 a year, but where physicians in general were making an average of $252,480 a year. Locally in like Baltimore area, because I know that a lot of you are at Johns Hopkins, the median salary for a psychiatrist is around $251 to $217, and in the DC area is around $272,038. So having a good salary, that's definitely a pro to being a psychiatrist and geriatric psychiatrist. There's a lot of great opportunities for work-life balance. We are in high demand. There's a huge flux of baby boomers coming in. So there's 1 in 3 persons that are at the age of 65 or older. They need specialist care. Things change when we age. So understand the physiology, the psychology at that time is very particular. And so we're able to set our own hours. Some of us, it's easy to own your own business in general as a psychiatrist. So if you're wondering, well, what field am I really into and how much flexibility do I want to be able to work on my own or start my own business? Think about psychiatry. You can also help a lot of people with their problems. A lot of opportunities here for research. I feel like psychiatry is sort of at the cusp where cardiology was 20, 30 years ago. There's a lot more growth happening, but there's still much more to do, much more research to be had, a lot of areas for people to find their niche and just add to the foundation of knowledge that's already here. We need really smart, very committed, very dedicated people who want to make a difference in the world. And the brain is like the most complex organ in the body. I have a lot of respect for cardiologists, but I do think that now there's a lot of destigmatization in education. There's a lot more support financially and in the government injecting legislation and some money into programs to support their human resource. And psychiatry is really just kind of a real vibration right now, and it's becoming more and more competitive at residency program levels as well. But you do also have the pro of getting to work with families. That's both a pro and a con. You work a lot with families, but also there's the con. It depends again on the family dynamics and caregiver burnout. There's other interesting aspects to working with family that arise. It can be stressful, like I mentioned earlier, but there's also a con in psychiatry where patients do present a real danger, not only to themselves, but also to others, and including us, you, the physician. I think it's one of the fields where a provider or physician is hurt in a given year. They become, you become one in a long and difficult process. You do spend a lot of time with your patients as well. And I think one of the hard parts about geriatric psychiatry is that there's not a lot of us. And so it's good in that we are a small group, maybe I think around 4,000 of us nationally, according to the AAGP, but very friendly people. But at the same time, in communities, there's a huge, like I said, demand growing. And so the possibility of being stretched thin as things in the years start to come out. I think for one of the things I wanted to stress about geriatric psychiatry in general is that it is unique more than adult psychiatry in that we do treat persons 65 years and older for geriatric populations, but they might have a late onset mental health disorder, not just one that's being carried on from their younger years. And so are unique in that way. We do have a lot of patients who also have multiple comorbidities. And so you need to be able to know your medicine very well, but also help them determine some of those medical conditions that they might not be able to do on their own. So you're also kind of like a family or internal doctor in some ways. You definitely are referring out as well for more evaluation and treatment and care. But because you're old, the patients are older, coming to you older, they tend to have comorbidities. They also tend to be on multiple medications. And so you're a pharmacist essentially too. You have to know your medicine very well. You have to know drug to drug interact very well and be able to be comfortable working with changing things, because the way that a patient was for many years might not be what they require now on a medication regimen that worked for them, and now having side effects or other medical needs that are necessitating priority in this case. And so you do, as a result, work a lot with other disciplines and specialties as well. And I think that's a really neat part about being able to collaborate or integrate other specialties in care with you. And not to forget, though, one of the overarching and main parts of geriatric psychiatry is also assessing and managing patients with neurocognitive disorders. And that's really such a huge part of what we do as well. Some other points about being a psychiatrist or geriatric psychiatrist in particular, you get to be, again, part of a very friendly group of specialists. There are so many careers in geriatric psychiatry itself. So I'm an outpatient psychiatrist, but you can do you can be a clinical educator, you can do primary research, you can do public psychiatry and community psychiatry, and you can overall so many other parts that eventually improve the quality of life and be present for a patient in their hardest moments. And I think that's it for me.
That was awesome, Dr. Phillip. Thank you so much. It was cool to hear that you studied at Mount Sinai. That's actually where I went to medical school. And I got my PhD there as well in neuroscience, which, as you know, there is heavily, psychiatry based. So I'm sure we know a lot of the same people. It was also nice to hear you talk about your drive to help people, and that is what pushed you to study medicine. And it's certainly something that influenced me to pursue residency training after finishing my PhD and being in that research world. And I did seriously think about going into psychiatry, given my training. Ultimately, I ended up in pathology because of my love for the laboratory. But it was really cool to hear about your background and your love for teaching and how that led you to psychiatry. I think there are definitely a lot of similarities between those professions.
Thank you.
Okay, great. So finally, we have Dr. Ali Jaber, who's a dentist here at Johns Hopkins.
Yes. Hi. Hello. Can you guys hear me well?
Yep.
Okay, awesome. I'm going to go ahead and share my screen because I did prepare a PowerPoint slide here. Can everyone see?
Yep.
Okay, awesome. Okay, I'm going to start on the slideshow here. Okay. All right. Okay. Hi, everyone. My name is Dr. Ali Jaber. I'm currently a resident here at Johns Hopkins as a general dentist. I'm going to give a bit of background of myself. So for my undergraduate education, I went to George Mason University in Fairfax, Virginia. I'm not sure if there are any Virginia natives here, but I was born and raised in Virginia. And I went to dental school at Howard University, HU, and I'm currently doing my residency here at Johns Hopkins. Now, a little bit of background of dentistry or life as a dentist. So doing this residency is actually something that's completely optional. So the good thing about dentistry is, you could do your 4 years in undergrad, you can go to dental school for 4 years, and you could actually just work straight out of dental school. However, I decided to do a general practice residency because I did not know what I wanted to do, because in terms of dentistry, you could specialize. There are different specialties in the field of dentistry. There's pediatrics, there's orthodontics, there's oral surgeons, and there's prosthodontists, and there's other types of other specialties in dentistry. But I mainly did not know if I wanted to be a general dentist or if I wanted to specialize. And I'm leaning more towards specializing in pediatrics. So hopefully in the next year or so, I'm going to be applying for pediatric specialty in dentistry. And I'm just going to give a brief overview as life as a general dentist, at least here at Hopkins as a resident. Our clinic schedule usually runs around 8:30 to 4 p.m., but sometimes I'm seeing patients at 8 o'clock. we tend to see about 8 to 10 patients a day, give or take. Some days it's a little bit slower where we see about 5 to 6 patients. The procedure that we mainly do on a daily basis consists of fillings, tooth extractions. Sometimes we do crowns, and we also do dentures. And, important things to consider in dentistry when we treat patients, it's not just about teeth. We also have to know about their medical history, their medications, any allergies that they have, any past surgical history, and whether they smoke or not, or any other recreational drugs that they take. And, all of these things are important because this has an effect of, what we treat with the patient. We use local anesthetics when we treat patients. So we use lidocaine, and patients that have heart conditions or any other comorbidities could have an effect while we're treating them. We just want to prevent any complications from occurring while they're on the dental chair. So I mainly made these slides for people that are interested in applying to dental school. I'd say that a lot of people get confused on how to go about in getting into dentistry. But I'll also talk about why I became a dentist later down the, as we finish through the slides, but I'll just go through here how to get into dental school. So the biggest thing is taking the DAT. So like applying to medical school, they have to take the MCAT. For dentists, you have to take the DAT. And it consists of several sections, which I will go over in a bit. I'll also talk a little bit about taking prerequisite classes because there's generally prerequisites that you would have to take before applying to dental school. Some other schools have specific requirements depending where you apply. So there's usually a guide that I will talk about later of dental schools that submit their information of what is required to apply to their school. There's also extracurricular activities that you could partake to show, in terms of leadership or if you have research experience. And also talk briefly about taking a gap year. Some people don't know whether they want to do dentistry or if they need some time due to burnout from undergrad and what to do during that gap year. So dental school prerequisites. So this is generally speaking a general overview of everything. At least when I applied to dental school, this is what was required generally speaking. So you have to take the DAT, as I said before, consists of several sections. So there's a biology section, there's a general chemistry section, organic chemistry, quantitative reasoning, which is math, reading comprehension, and a section called perceptual ability, or the PAT. It's pretty much knowing or learning how to figure out three-dimensional figures. It's very interesting, but there are definitely several resources that you could use to prepare for the DAT. So there's the DAT Bootcamp. It's a very common resource. There's another resource called the DAT Destroyer, and there's videos for general chemistry and gen chem, such as Chad's videos. And when I was an undergrad, I had to take 2 semesters of biology, 2 semesters of gen chem, organic chem. I also have to take physics, 1 semester of English, 1 semester of biochemistry, as well as math. So I took pre-calculus. And as I said before, some dental schools have other requirements and they have recommendations. So when you're in dental school, you're not just taking general biology, you have to take some anatomy courses as well as histology. So they usually recommend that you take those classes in undergrad. So when you're in dental school, at least you would have an idea of what to expect when you're taking these classes, because dental school is pretty intense. So I think I remember in my first year of dental school, I was taking 10 exams in a week. It was pretty crazy. And also some dental schools don't accept online classes, so such as UCLA. So just make sure when you apply to dental schools or whenever you're selecting your dental schools, what classes they require and whether they take any hybrid classes or not. And also if you went to community college and transferred to a 4-year university, sometimes some dental schools don't accept those prerequisite classes. So if you took biology at a community college instead of a 4-year undergrad institution, they might not accept it. And letters of recommendation, usually it's a maximum of 4. You could use 2 recommendations from your science teachers, could be 1 from your dentist. Clinical experience is also another thing. So when you shadow your general dentist, or if you want to shadow a specialist as well, that's also something that you can do. And you could do some volunteer work as well. You could partake in mission trips such as the Mission of the Mercy or RAM. I'll get into that a little bit later. And research is not necessarily required. I know for medicine, I know some institutions or a lot of medical schools want you to do research, but for dentistry, it's not necessarily required, although there are some schools that do focus on research. So, and this is what I was talking about earlier. This is a general, this is the ADSES guide, which pretty much gives you a breakdown of the average DET scores and GPAs and costs of each dental school and the percentage of the most recent class. And I believe this is from 2017 when I was applying. So you can see here, this is VCU and Howard University. I went to Howard. So that's basically the breakdown of their mean average scores that they took in, and as well as the GPA and the cost for in-state and out-of-state. And generally speaking, I would say the best dental school that you go to is the cheapest dental school, because dental school nowadays is pretty expensive. So you have to look into whether you're applying to a private school or a public school. It makes a big difference, especially if you're an in-state resident. You definitely save a lot of money in the long run. But there's nothing wrong with going to a private school as well. Sometimes private schools offer more resources in terms of what you can do in clinic. So that's another thing that people consider as well when they apply to dental school. And this is, I believe, this is another school that I put in here. And the application process. So I usually recommend that you keep a folder to keep everything organized. So have your personal statements in there, the guide, the list of schools that you want to apply to. And, with any, applying to medical school and dental school, it's the same thing, getting a personal statement, talking about why you want to become a dentist, what inspired to do this. And there's information on the ADA website right here that I provided below. If anyone wants these slides later after this, I could be more than happy to email it to you. And meeting up with your professor as well as your advisors, going to open houses that dental schools sometimes offer. I know with COVID, it's been different, but back then, a couple of years back, dental schools all the time had these open houses where students can go in and meet the faculty members there and get to know about the school more and get a tour. And there are several programs that people that are interested in dentistry could apply to get a more of a exposure of what dentistry is like or what dental school is like. So there's this program called the Summer Medical and Dental Enrichment Program. So I know this is also integrated with medical, but I know at least for the dental side of things, this is a program that's really nice for freshmen and sophomores in undergrad. The application usually opens around November, and it's a first come, first served basis, and they have like a minimum GPA of 2.7. So it's pretty much accessible for anyone to apply. And you pretty much learn more about dentistry in terms of, going into the dental school labs and doing some preps with the high-speed handpiece and all that. So it's pretty cool. I also attached the website below if you want some more information. And this is another one specifically in VCU called the Summer Academic Enrichment Program, where they actually provide you with a cool stipend, where you pretty much live in their dorms for a couple of weeks and you take classes there, like dental school level classes. So you get a good feel of what dental school is actually like. They usually require you to submit some letter recommendations, as well as your transcript and personal statement and all that. And some frequently asked questions that I get all the time while I was in dental school was, what is shadowing, right? Shadowing is when you observe the procedures done at a dental office in your own free time. And I actually have a lot of people come up to me telling me that they're a dental assistant and does that count as shadowing? No, it doesn't, unfortunately. Although being a dental assistant does quite help a bit while you're in dental school, anything that's paid is not considered to be shadowing in dental school, or at least when you apply to dental school. And they actually place a really heavy emphasis on that. They just want to make sure that that you want to get into dentistry and this is something that you really want to do. Because, going to dentistry or applying to dental school blind without shadowing at all or knowing what the procedures are like is kind of like digging yourself into a hole, right? Now, how can you get started with shadowing? You could ask your family dentist that you see, or you could participate in other volunteer events, like I mentioned before, like the Missions of Mercy Project. I believe University of Maryland offers a Mission of Mercy event in, I think, around spring of every year. as well as remote area medical. So this is also, they also do medical or medicine related volunteer events. I'm not quite familiar with that too much, but I know for dental, they go across the entire country, which is pretty cool. Another thing, when does the application cycle usually open up? It's around June 1st, and provided information there on how to sign up for the DAT. And if you don't know where to start, you just go through a content review of your subjects that you learn in undergrad. And as I said before, participate in programs such as DAT Bootcamp. Those prep resources are very helpful. Although it's kind of costly, it's really worth it at the end. And, don't take the DAT just to get a feel for it. Make sure you're really prepared. I made the mistake just to take it for the sake of taking it. And it was a really big mistake and a lot of money that costed me as well. And what GPA and DAT do I need to be considered competitive? Generally depends on the schools that you apply to. So according to the ADA website, the average GPA is around 3.3 or higher. It's a little bit lower than medicine, I think, overall, if I'm not mistaken. And as of, I believe this is information from 2017, the national average of the DAT is around 17, but usually a good score is around 20, and the score is out of 30. So generally speaking, 30 is a perfect score. Usually a really good score is around 20 to 21 per se. And if you don't have a strong GPA, you could always make up for it by going to a post-bac program, usually about a year. Sometimes you can go to a one-year master's program as well. I know there's one in Florida with Barry University. I had a couple of friends of mine in dental school that did not have strong undergraduate GPA. So, they took a master's program. They excelled really well in it. And that got them in, So if you don't get in the first time, it's okay. There's other things that you can do to compensate for it. Why did I become a dentist, though? I like working with my hands. I've always helped my parents out with renovating the house as a kid, and I always wanted to do something with medicine. And I always liked going to the dentist when I was a kid. My dentist was very, very nice with me. So when I was in high school, I was like, hey, let me just shadow my dentist and see what it's like. And I loved it, honestly. And yeah, that's pretty much it. If anyone has any questions, feel free to ask. And if anyone wants these slides as well, I'd be more than happy to share it with you. Thank you.
Thank you so much. That was awesome. And that was really a great resource to learn about the specifics of getting into dentistry. And I think that presentation was a great resource for all the participants today. Mm-hmm. So at this time, we'll start to wrap up. I'll make a few comments, I guess, just to fill in some of the blanks on some of my observations. I really appreciate everybody's time. And I thought it was great to see 3 health professionals who do really radically different things. But I thought that there were some common threads through the different presentations. And I think at the end of the day, what it comes down to is having an urge or a desire to help people. And I think that for the participants here today, it's something that if you're sort of thinking about or feeling that you want to, obviously you don't have to be a doctor or a health professional to help people, but I think that if that's something that's calling to you, then I think getting into medicine or dentistry or any sort of health profession is such a rewarding and fulfilling profession to get into. And I'm thankful every day that, when I go to work, I come home and I feel like I've helped somebody. And I just think that that's something that I'm grateful for. And I'm sure that all the panelists would agree with